Welcome and good evening, everyone, to tonight's webinar event. Before we begin, just a few reminders to anyone new to the SAB webinars. Right now, everyone is in a muted only mode, and if you have any questions throughout tonight's presentation, we encourage you to submit them. You may do so by using your question feature. It's located on your control panel with a little drop-down arrow. We will address all the questions during the Q&A portion at the end of the presentation. At this time, I'm going to hand it off to Dr. Jaspal Singh, who is the current SAB's Vice President, to get us started, and thank you all for joining.
Yeah, thanks, Emily. Welcome, everybody. I'm Jaspal Singh. I'm so excited tonight to moderate this presentation tonight. Tonight we have two fantastic speakers. We're going to talk about the pulmonologist's role in precision medicine for non-small cell lung cancer. First speaker will be Dr. Adam Fox. Dr. Fox is a pulmonologist and health services researcher at the Medical University of South Carolina, who did his fellowship at MUSC as well as a master's in health services research at Northwestern University. He has a clinical and research focus on lung cancer diagnosis and biomarker testing, which would be great, and fits right in. And then also Dr. Gerard Silvestri, who's a senior vice chair of faculty development and the Hillenbrand Distinguished University Professor in the Division of Pulmonary Critical Care Medicine, also at the Medical University of South Carolina. Dr. Silvestri, as many of you know, probably does not need an introduction in this space, as he's an international expert in this area of precision medicine. And we're going to keep the intro short because we're hoping to get through this presentation and have some time for questions and answers. And thanks so much. Adam, you want to start?
Of course. Thank you all for inviting us to speak tonight. Thanks for everyone who's here. The talk will be on the pulmonologist's role and how precision medicine may be changing that role for lung cancer. And then, oh, here we go. I was asked to sit on this slide for just a few minutes for disclosures. You can take a minute to see these here. And then is also asked to have a disclaimer that Dr. Silvestri and I are solely responsible for this presentation and not the society. And we'll go through these objectives. These were sent to you in the email. So I wanted to start off talking about the future and the past here a little bit. This idea that precision medicine and precision oncology treatments are changing the way that lung cancer is diagnosed and treated. These targeted therapies that are being developed and being deployed, they're really focused on individual characteristics of patients' tumors. So these comprise of mainly tyrosine kinase inhibitors for the targeted therapies, and then for immunotherapy, those are really mostly antibodies that are disrupting the interaction between the cancer and the immune system, and that's fairly different than traditional chemotherapy, or what we would call traditional chemotherapy now, and that those really attack all of cell cycle division. And so they're really the opposite of a targeted therapy in many ways. And this is a really nice figure that looks at actionable biomarkers over time. So this pie chart on the far left is from 2012, and it looks at, well, what percent of patients have an actionable biomarker. And you can see the large blue area here of unknown, about half in 2012. We just didn't have a driver mutation, or at least an actionable marker for those patients. And as you go through time to the far right pie chart of 2021, it comprises of mutations, and in that bright blue field, a very high PD-L1 score. And you can see the wedge in green up top, the 11% of unknown. The amount of people who aren't going to have a biomarker that helps direct their treatment, especially at the metastatic stage, is shrinking just over these last 10 years on this slide, from 2012 to 2021. And so what are targeted therapies? Many of you are probably familiar with this, but most targeted therapies are pills. They almost all have indications at the metastatic stage. Some have indications earlier. And in general, they all have a favorable toxicity profile compared to chemotherapy. They certainly have adverse events and contraindications, but compared to chemotherapy, they are much better tolerated. At the bottom, you have a list of all of the driver mutations that we know of that have therapies with indications for non-small cell lung cancer. And then just to show that timeline again in a different way, this is each of those mutations and when they had their first approval in lung cancer. So a biomarker matched with a therapy in the timeline, just about every year we had a new biomarker and a new therapy. Certainly this is not all the indications, because each of these or multiple of these will have multiple indications across different stages. So just a quick breakdown of how these work. Targeted therapies on the left, you can see this EGFR receptor, this epidermal growth factor receptor in a cell membrane, and osimertinib comes and disrupts the function of this receptor, and you can see the pathways at the bottom, like the RAS pathway is now disrupted by this small molecule inhibiting this function. And on the right side, the cancer cell and immune cell often interact through this PD-1, PD-L1 interaction. And this PD-L1 molecule on the cancer cell lets it evade the immune system. And the antibody in between them is to kind of show that it's disrupting this interaction and allowing the immune system to target this cancer cell. So I wanted to briefly just go over the guidelines for biomarker testing before moving into the following slides. There's pretty good consensus that broad molecular profiling is indicated for all patients with advanced and metastatic cancer, especially those with a non-squamous histology. And so in the current state of the art, broad molecular profiling generally means testing DNA and RNA with next generation sequencing, or NGS sequencing. In the second bullet here, there's a little caveat for squamous cell histologies, because they are less likely to have actionable mutations in terms of oncogenic driver mutations, EGFR, ALK, etc. And so the guidelines say to consider squamous histology. They don't particularly give advice on what to consider this based on, except for those with young age or no or low tobacco exposure. They mentioned that you should maybe especially consider it in those circumstances. The rate of actionable mutations are low, and young age and low to no tobacco exposure does perhaps increase the likelihood of those. But I believe many places are kind of, and our institution included, are starting to test all of these, because there's a lot of problems with young age or low tobacco exposure, with quantifying that and trying to keep implicit bias out of the equation for that kind of recommendation. And so that's kind of maybe our take on it, but this is what the guidelines would say. And then those first two bullets are really about the sequencing needs to look for oncogenic driver mutations, keeping in mind that PD-L1 is a protein, not a genetic mutation. And so all patients with advanced and metastatic lung cancer, regardless of squamous or adenocarcinoma histology, should be tested for PD-L1. And then for the early stage, this last bullet is kind of for the earlier stages, 1B to 3B, at least you should have PD-L1, EGFR, and ALK. I think that many, especially if they're proceeding to surgery, let's say, the guidelines get a little fuzzy about whether this is just for the resectable patients or for all patients of these stages. But I think most of us are kind of straying away from these kind of spot mutation analyses of just EGFR and ALK, and still trying to send a full kind of panel for patients with maybe locally advanced lung cancer. So I want to, as a basis for some of the discussion on how things are changing, I have to review at least some of the major trials that are changing treatment paradigms for lung cancer. So starting with lung cancer that is resectable or resected, let's say, this is an adjuvant EGFR therapy trial showing patients with already resected 1B to 3A cancer with an EGFR mutation. In this trial, they were randomized to osimertinib or placebo, and you can see easily at a year the disease-free survival in the patients who were treated with osimertinib maybe 3 or 4% had detectable disease compared to about 65% or 35% in the placebo group there. So a pretty stark difference in even just a year here. Pretty similar trend here with adjuvant out therapy. This was new just this year. So for patients completely resected stage 2 to 3A in this case, they had a known ALK rearrangement. They got the targeted therapy for 3 years or until recurrence in the trial, and you can see that patients with the drug had a longer time alive or free from disease. There's trials over the last several years showing immunotherapy in multiple fashions. This is kind of maybe the newest of these trials. You could always get neoadjuvant chemoimmuno alone, or even just after a surgery getting immunotherapy. Those are slightly older now. This trial is currently sort of in favor, let's say, and for patients with stage 2 to 3B even lung cancer, if you only have N2 involvement for that 3B, they might get neoadjuvant chemo and immunotherapy, and then after surgery get more immunotherapy. And this was one of the trials that really led to this recommendation. And you can see again the benefit in overall survival this time after about that 2-year mark. So to pivot to the unresectable stages, this is an immunotherapy for patients without an actionable mutation. So you can't have an EGFR or ALK mutation. These patients would get chemo, radiation, and then added immunotherapy. This, I think, is well within the standard of care these days. It's notable that before enacting this paradigm, we would like to know the EGFR and ALK status, as with all of these paradigms that have immunotherapy, because of the low response to immunotherapy by patients with these mutations. In switching from immunotherapy to a targeted therapy, especially EGFR and ALK therapies, have a risk of increased drug reactions, particularly pneumonitis. So often, if you need to do that, you would have a washout time ideally. So that's one more logistical concern that these trials really bring forth. We're almost done with the Rote trial data here. This one is also brand new just this year for patients with unresectable stage 3 with an EGFR mutation. They got chemotherapy, radiation, and then an EGFR targeted therapy. And this is for progression-free survival. And you can see the pretty dramatic difference here. Median time of progression-free survival was only 5 months in the placebo arm and 39 months. And that should not be with immunotherapy. My apologies. That was the drug was osimertinib in this trial. So again, every year we're getting maybe not a new mutation, but definitely new indications that we'll have to work into our practices. So the last two here, these are probably mostly familiar to everyone on the call. This is osimertinib for patients with metastatic lung cancer. And in this trial, it's not really fair because this is osimertinib compared to an older generation EGFR tyrosine kinase inhibitor. I've overlaid an older trial from the late 1990s here to really show you what the benefit is of these drugs. This is the survival in metastatic lung cancer for supportive care plus chemotherapy or supportive care alone. And I think that really tells the difference in how important these medications are for these patients with this mutation. And then a very similar trend for alectinib for patients with ALK rearrangements. Again, the x-axis here is on the order of 5 years. So in this trial, median survival in 5 years was not reached in the alectinib arm. So this represents, in these smaller percentages of patients who have these mutations, really important therapies that we have to identify. Last one, metastatic stage for immunotherapy. This is for an older trial that had patients who were just a high PD-L1 score, greater than 50%. They get immunotherapy alone, and you can see the difference in progression-free survival here. So I wanted to end this section on the trials with two cases. You can see on the left panel here, this patient presented with kind of a nodular, maybe you'd even call it a consolidative type appearance, but clearly nodular lesion. And on the PET scan, those more dense nodular areas did have petavidity on the bottom panel there. And then in the right panel on the PET scan, this was the only lymph node that had any adenopathy detected on PET, but certainly has a positive paratracheal node here. And so this patient did have lung cancer, diagnosed off of that paratracheal node, and with all other lymph nodes in their mediastinum being negative for malignancy. And so this is a clinically T2N2 M0 non-small cell lung cancer, stage 3A. And the treatment options for this patient in the setting of these precision medicine treatments that we now have available really bring home to me how important it is to get this information as quickly and efficiently as possible, and to have multidisciplinary meetings and tumor board meetings and otherwise to try to figure out the best strategy. So in patients, if this patient was resectable, then we need to know if we need to get them lined up for neoadjuvant chemotherapy and immunotherapy. And we really, again, we wouldn't want to do that if they harbored an EGFR mutation. And then likewise, if they were not deemed a surgical candidate, then we would need to get them lined up for the appropriate unresectable treatment. So would that be chemotherapy and immune therapy, or chemotherapy and EGFR therapy? And again, we would not like to switch from one to the other if at all possible, because of those. One, it's a medication that is not likely to be effective, so we're just exposing patients to harm with very little benefit. And if we have to switch them quickly because their disease is rapid or has a dangerous structure involved, then we're increasing them to increase risk of pneumonitis and other complications by having both of those drugs given so close together. So everything about this patient's initial treatment or how to handle their perioperative treatment all hinges on getting appropriate staging and biomarker testing. Coincidentally, this patient did have an EGFR mutation and did just, I think, very recently get surgery. So she'll be meeting with her oncologist to potentially start osimertinib in the short future. I have one more case to close out this section on biomarkers and these different stages. This was an 86-year-old, really active, avid cyclist who presented initially with hemoptysis. He'd never smoked in his life, and he had this area. We got a robotic bronchoscopy performed for him that did show squamous cell carcinoma. And despite his age, he was, again, in a fantastic shape. Mediastinum on PET scan and with EBUS TBNA showed no evidence of disease. And so after meeting with a surgeon, they decided to pursue a VATS with a planned resection. But unfortunately, when they started the procedure, there was chest wall invasion that was not apparent on previous imaging, along with small distant pleural mets that were also not seen on CT or PET scan. And so surgery was aborted because he had kind of a surprise occult stage 4 disease. Shortly after, weeks later, he presented with a hemothorax, unfortunately, as well as a new extensive DVT in both bilateral extremities. To cut it short, we were able to sort of nurture him through this. He had a filter. He was in the hospital. He went from cycling to barely walking across a hospital room when I saw him. He did not have an actual mutation, which again statistically is more likely for patients with squamous cell carcinoma, but he did have a PD-L1 tumor proportion score, or PD-L1 score of 50%. And given his age and his kind of debilitated status, he was offered immunotherapy as a monotherapy. And as that high PD-L1 score would predict, he had a really amazing response to therapy. And so he's now back to cycling. His pleural effusion has resolved, and he has this kind of small little scar-like area on his last scan, you see in the bottom right there, really doing fantastic. So to kind of summarize the importance of biomarker testing and why we need to have this in the back of our mind for all of the patients that we see these days, is that as early as stage 1B, anyone who's receiving resected for something greater than 1A and 2A, neoadjuvant and adjuvant therapies have indications currently, and biomarker testing is going to help us choose between those. For unresectable 1B to 3A, there's now both options, both EGFR therapy, targeted therapy, or immune therapy. And if they don't have EGFR mutation, but they've got another oncogenic driver, well, if they do have progression or recurrence, then biomarker testing informs what is their next therapy going to be. Because even in definitive chemo-RT approaches, cure is not 100%, of course. And then for stage 4 disease, it informs the first treatment this patient should get to have these biomarker tests. So I've got just a few more slides here before Dr. Silvestri takes over to really introduce the problem with this. So we've seen these remarkable advances and improvements in survival. We're even seeing that like on a population scale in large registry databases. But the problem is that people are not being tested. So this is one large oncology network, one of the newer kind of a little bit bigger populations looking at testing rates. This was patients just with metastatic non-small cell lung cancer. So I would argue that it's always important for biomarker testing, but this is a particularly important group. Mortality is high, it's quick, and biomarker testing informs the first thing that should happen. The time frame is recent, 2018 to 2020, and you can see in the table out of 3,500 patients roughly, the proportions of patients with at least one biomarker is pretty low, as 80% had one. But if you look at EGFR, ALK, BRAF, and PD-L1, they're all kind of in the 70 to 80% range. And if you look at just these 5, only a third had all 5 of these biomarker testing tests back prior to receiving their first line of treatment. So the last thing I'll introduce here is something that we'll go over as we talk about the pulmonologist role more in depth, and also the importance of efficiency in this pathway. And so most people go through, maybe not always quite this linearly, but through some kind of suspicion for cancer, a biopsy being performed, cancer being found on one or some of these biopsies. Eventually, someone orders the biomarker testing and it's sent off either internally or externally to a molecular laboratory. And then eventually, the final step is that these results are available to the treating team, oncology, surgeons, and others, as to how does this potentially change the treatment paradigm, of which there are so many. And so Dr. Silvestri and I, some of the next slides will contain some data from our lab. We had these questions of, well, where do pulmonologists fit in? What do we know about biomarker tests? How do we go about it? How do we practice getting biomarker testing done with bronchoscopy? And what do we know about these individual biomarker tests and therapies?
Thank you, Adam. Could you go to the next slide? So 2 things come to mind for me out of everything that Adam talked about so beautifully. There's this sort of confluence of 2 events occurring at the same time. One is precision medicine and these incredible new targeted therapies that have survival rates in the 40 and 50% range, even for metastatic disease. And that is working downward from stage 4 to stage 3 to stage 2 to stage 1B. At the same time, we now have indications that surgery which was really confined to stage 1 and 2, is now moving up from stage 1 to stage 2 to stage 3 and moving into the adjuvant and neoadjuvant setting. And so the treatment paradigm has changed dramatically just over the last 3 to 5 years. And we are incredibly well positioned as pulmonologists to make sure that we're on the front line of that decision making, but it all starts with the tissue. So the NCCN guidelines said a major limitation in obtaining tissue for molecular testing for non-small cell occurs when these minimally invasive techniques are used. The yield may be insufficient for molecular biomarker and histologic testing. Therefore, bronchoscopists and interventional radiologists should procure sufficient tissue to enable all appropriate testing. And so, like, I don't actually care that much about knowing each of the targets. What I need to know is that my pulmonary community is getting enough tissue and understanding how quickly it gets to pathology and gets tested for these markers. Next slide, please. And so I think there's a misnomer out there that people think that a pass in a single lymph node, 3 passes is all you need. And I'm going to show you some data from our lab that shows that we think it's only 3. That data actually comes from Hans Lee in 2008, and it looks like that data is around the sensitivity of getting malignancy, not biomarker testing, but malignancy. And after 3 passes, you get to about 95%, but you don't get much more after that. So I think people believe that 3 passes from a lymph node, even with malignant cells on all 3 passes, is enough. But I can assure you it is not enough. Next slide, please. When we look at, well, let me talk about this first. The CHEST guidelines on EBUS recommend the use of either a 21 or 22 gauge needle. In the absence of rapid on-site rows, suggest that a minimum of 3 passes is there for a diagnosis, but that's not for molecular testing. For diagnosis and staging, they recommend additional samples beyond those needed to establish the diagnosis to be used for molecular analysis. Next slide, please. So there's one meta-analysis on this with 21 studies and about 1,100 patients. The pooled proportion of adequate EBUS TBNA samples for NGS testing was 86%, which is actually really high. And they modeled the yield rates, and at about 6 passes, they had a 95% yield. So as opposed to 3 passes, again, we would take 6 passes in our lab. Now we have on-site cytopathology, and our cytopathologists attendings are excellent, and they'll tell you, hey man, you got enough. You know, sometimes, and I think people who do EBUS, you know, kind of go in there going, I know I got it, and then they spray it on the slide, and the cytopathologist looks at it, and there may be some malignant cells, but they're scant. You have to have enough DNA. So again, if the patient's quiet on the table, the more passes, the better. Next slide, please. And this is just that the curve to show you up at the right-hand end that 6 passes gets at 95% of samples for NGS testing. Next slide, please. Except that's not actually what we're doing. Adam Fox is lead author on this article from our lab, where we interviewed more than 400 pulmonologists through the CHEST database, and we sort of asked them, hey man, like, tell us how many passes you use for biomarker testing. And you can see that more than half are stuck in that 3 to 4 passes range, which was adequate to diagnose lung cancer. So they were correct 10 years ago. They may even have been correct 5 years ago, but they're certainly not correct now. Look at the 14% there that do 0 to 2 passes. To me, like, that's a drive-by EBUS. You know, hey, I'm in the neighborhood and I'll just drive right by. And then you can see 5 to 6 passes in a quarter, and then 7% had more than 7 passes. And by the way, the people that took 5 to 7 passes were more likely to be interventional pulmonologists and academic pulmonologists. So we really need to get the message out to everyone, but particularly community pulmonologists who are doing EBUS. Next slide, please. And if you look at what they're testing, we asked, what are you testing? And you can see that overall, the testing rates for EGFR and ALK, and if you recall, from Dr. Fox's slide, those were the first discovered, so people were more familiar. But look at, as we go down the line for the different mutations, you can see that a couple things. One is that the academic sites in blue do more than the non-academic sites, than the community hospital setting sites. And so again, we should have that up above 80 or 90% for all of them, but particularly the newer ones. And I always say this when I'm talking about this. Listen, ROS and BRAF only represent 2 to 4% of the mutations total. But if you have that, if you're the patient who has that mutation, it is the home run ball. The targeted therapies for that are leading to 5-year survivorships in 40 or 50%. And I'm old enough to remember, and Adam, I think, showed you on the slide, when we just had traditional chemotherapy and almost everyone with stage 4 disease was dead in a year. So these things, even though they're rare mutations, they are incredibly important to patient success. Next slide, please. So we asked in a separate publication of the same group, and we published this online, a separate survey, and we sort of wanted to know, like, where do pulmonologists feel like they fit into this whole paradigm? And what was so interesting to this is it seems to us that pulmonologists stop at the biopsy. They think they're responsible for that. 83%, 15% they would send to transthoracic needle aspirate or to someone else for the bronchoscopy. Staging, most or all of the time, they think they're responsible. But honestly, I think we're really well positioned to do the staging, make sure that there's no brain mets, do a PET scan, look for mediastinal adenopathy or other metastatic disease. I feel strongly that we need to get that number up. It's interesting that pulmonologists don't discuss biomarker testing. They feel that's the realm of the oncologist. I sort of agree with that, except I think one of the things that we should be talking to our patients about is this amazing outcomes we can see with biomarker testing, the importance of biomarker testing, and the importance of waiting for the result of that test, telling them they need to be patient as that testing gets done and they're getting ready to see their oncologist, because the best decision their oncologist could make is based on the therapies that are only based on whether you have appropriate tissue and that tissue is tested. Now, the next column is the ordering biomarker testing. We don't do that much, but there's actually probably an important reason to do that, and I'll get to that in the next few slides. Communicating the results, I really do feel like it's okay for the oncologist to communicate those results. I will say this, though, if they're on a PD-L1 inhibitor immunotherapy, we do see those patients back with some of the side effects like pneumonitis from that. So we should know a little bit about how to talk to patients about these targeted agents. And then education for patients. Look, like, we're the front line in lung cancer as pulmonologists. We should have some form of education, whether that be through our nurse navigators, whether that we could do it through media, whether we could do it through handouts. We should be educating our patients about precision therapy. And the really important reason for that is this is not your grandfather's chemotherapy. Patients are very nihilistic, and I think physicians, some of them are, about lung cancer treatments. And these treatments are well tolerated in the outpatient setting. Some of them are pill forms of therapy. And we don't want our patients not to at least think about using these therapies that can be life extending with a good quality of life. Next slide, please. And the barriers for the oncologist, this is a survey I did with a woman named Katie Milheim, and we asked oncologists about their concerns. And their concerns are respondents concerned about delaying treatment. The medical oncologists, 45% say rarely or never, but some of them say always or often, and they'll start traditional chemotherapy while they're waiting for the biomarker test result to come out. And then there's patients who desire immediate treatment. And I think that sometimes and often over 30% say, look, I'm nervous about this. It's stressful. I want to get my treatment going as soon as possible. And then about inadequate tissue for testing, and this was 170 respondents, they worry about that. Oncologists think that that's a barrier, and it is a barrier when we don't send enough tissue. Next slide, please. So this is data that's unpublished from our lab, which is remarkable. And Adam and I looked at over 200,000 patients in the SEER Medicare database and asked the simple question, who's not getting treated at all for metastatic lung cancer? If you look at the black line at the bottom, you'll see that only 35% are being treated. Now, we asked a bunch of medical oncologists at a meeting, just, hey, raise your hand. How many patients do you think we don't treat for lung cancer at all. And they say, oh, only 10 to 20%. And what we found out is they're actually correct. If it gets to a medical oncologist, most of them get treated. But look at this look at these lines here. We tried to favor treatment in every way we could. So the full group's only getting treated. Over 200,000 patients, only 35% are getting treated. If you go up that bar, you get to adenocarcinoma, which is, again, a lot of oral therapies for adenocarcinoma, you get to 45%. If you get at least a referral to oncology, you get to almost 50%. If you survive 90 or more days, you get to about 55%. But look at that top bar there. It says that 40% of our patients with lung cancer die within 90 days. And that puts the pressure on us as pulmonologists to diagnose those patients quickly and get their markers quickly so that they can get first even an infusion of immunotherapy, for example, which might turn them around, as it did for Adam's 86-year-old bike rider. Next slide, please. And so one of the things that we looked at is also the percent of patients who are being, in that group of 200,000, the percent of people who are being even biomarker tested. And in the no treatment group, only 14% are getting treatment, even in the most recent data, 2015 to 2019. In the treated group, about a third. So one of the things that this goes to sort of show you is that look, if you don't get tested, you have no hope really for getting treated in these groups. Next slide, please. So this is sort of turnaround time, and we sort of published this from our survey data of pulmonologists and asked them, like, hey, how long do you guys think this stuff takes? And so, lung cancer suspected, how long does it take to get the pulmonary appointment? Well, 1 to 3 weeks. How long does it take to do the biopsy after that? Well, 1 to 2 weeks. How long does it take to get the lung cancer confirmed? 0 to 1 weeks. And then how long does it take to get biomarker tested? 1 to 2 weeks. So even if we collapse everything to the shortest amount of time that a pulmonologist thinks this should happen, we are talking about 5 weeks. But I can assure you, Adam and I are looking at a very large database that this takes much longer than that, much significantly longer than that. And one of the real important places that we could make a change is when we perform the biopsy, if we had some reflex testing. So once it gets down to the pathologist and the pathologist says you have cancer, it's non-small cell, and that triggers an automatic, and we know the patient's metastatic disease, or even now 1B through 3A, and it triggers an order that can be written that the patient then gets the biomarker testing done. That could shorten the time dramatically. Next slide, please. So this just shows you about how we could shorten that dramatically. Single hospital molecular lab did this study, and it's kind of an interesting study between 2016 and 18. The intervention was the pathologist orders institutionally approved biomarker panel for any patient with newly diagnosed adenocarcinoma of the lung. So the year prior to the intervention, the average turnaround time from start to finish was 52.6 days. Remember, 40% of our patients are dead in 90 days, right? So this is almost 2 months already burned up. And then the intervention year, it was 26.5. So they got the intervention, they started to lower their time. And then 1 year after the intervention, they were down to 2 weeks. So the average turnaround time decreased by 37 days. Adam's Career Development Award in lung cancer is going to really focus on how can we implement reflex testing for biomarkers in community and hospitals in underserved community settings, rural and underserved areas. So you can see that how utterly important this is. And I know I'm talking to pulmonologists and going, hey, Gerard, like, we're so busy, but we're like, hey, man, we're making the diagnosis. Why are you killing us with all this? I'm killing us with all this because honestly, this could be life-saving stuff, and the reward is what we do every day, and we are the first person to see most of these patients with lung cancer. Next slide, please. So the take-home points are here. Biomarker testing impacts the treatment of lung cancer and the outcomes across most stages, from 1B all the way to 4, we think that we need to do next generation sequencing on all patients with non-small cell lung cancer, at least PD-L1 on squamous, but we're in fact ordering it on all our patients. I would also let you know that 10% of lung cancer biopsies have an adenosquamous histology within them. And so you might be biopsying the squamous area, but there may be adenocarcinoma in that. So we're doing that. There's a huge change in the paradigm for treatment of lung cancer, making biomarker testing needed, and I would say really needed. And I think we're all going to have to figure this out together. I think we got to work to obtain adequate tissue, and for me that means 6 biopsies, 6 passes through a lymph node. The more the better, so that we get adequate tissue for our pathologists to work with. And pulmonologists really need to work in a multidisciplinary fashion to facilitate timely testing. And I'm always asking people, I'm always asking when I speak around this about this around the country, I say, hey, look, like buy a cup of coffee for the pathologist, go down, they're always in the bowels of the hospital somewhere. The poor ladies and gentlemen don't get to see folks very often. Go down and meet with them, buy them a cup of coffee and say, hey, like, let's talk this through. Let's talk about what we need. Let's talk about what medium you'd like it in. Let's talk about whether we could have on-site cytopathology. Let's talk about reflex testing. Hey, me, you know what? I'm going to buy 2 cups of coffee, and we're going to get you guys, and we're going to get the oncologist, and we're going to sit in the same room. We're going to have like a little, I'll even buy some Dunkin' Donuts, man, and or Krispy Kreme, depending on what part of the country you live in. And let's get together and talk about this care pathway. It won't take you long to do that, and I think your own job satisfaction around cancer care will be improved greatly. So on behalf of Adam and Jospo, I thank you guys so much for your kind attention, and I guess Jospo will open it up to questions from the audience. Thank you again.
Well, just those are phenomenal. The slide decks was great. The information was fantastic. Taking a lot of notes actually here, and I think this rings well with our audience actually. A lot of the stuff that you're kind of getting at. Sounds like we're not doing a great job with molecular testing that we could have. So you mentioned the 6 passes. I'm going to sort of change gears a little bit. We were talking earlier before we started here how the landscape has changed. Like I think we're getting better and better at knowing node. Like we have bulky nodal disease. I think a lot of us are getting more comfortable taking aggressive biopsies. How about in the periphery? I'm sort of at the more the point of like trying to understand how much do we need to do all this stuff, or are we over testing because testing comes with expense? Testing comes with some of the testing costs are attributed to the surgeons. Our surgeons don't necessarily always want us to do all the testing, and we don't know with early stage disease where it fits in. And what piece of advice do you give us in that space?
If you don't mind, Adam, I'll take this one. So first of all, for a small peripheral nodule, if it's not 1B, so larger size nodules, I don't think you need to test at all. If it's a stage 1A, they're not eligible currently. There are actually some trials going on, but currently they're not eligible for anything. 1B through 3A, so 1B and 2, those are larger nodules or have hilar adenopathy. I think they need to be tested. And the reason for that is 1B and 2 and resected 3A, but let's stick with 1B and 2. There's 2 options here. One is adjuvant therapy after surgery, and one's neoadjuvant chemoimmunotherapy. So adjuvant therapy for EGFR and ALK, and neoadjuvant chemotherapy and immunotherapy given before surgery. But to know that before you investigate that treatment strategy, you have to know prior to surgery or prior to instituting neoadjuvant, you have to know that they're EGFR and ALK negative. The only way you can know that is by testing beforehand. So for 1B and 2, no question in my mind, you should have at the very least EGFR, ALK, and PD-L1 status. If they're EGFR and ALK negative, then they're eligible for neoadjuvant chemoimmunotherapy followed by surgery. If they're EGFR and ALK positive, they should go directly to surgery, not get immunotherapy. And I think this is a tough discussion to have with surgeons, right? Like, you know, sometimes they either want to jump in really fast and go right to surgery, or the opposite is they want to do neoadjuvant and commit to a neoadjuvant protocol. And I think we're going to have to learn more about this as we go along. But for right now, I would submit for the small peripheral nodules, anything less than 3 centimeters, I don't think you should do any testing at all. I mean, those are people you will make a diagnosis, and if it's cancer, they go to surgery if they're a surgical candidate.
That's important. I think that's great. And then the aspects of, nodal biopsies, you mentioned 21 gauge and 22 gauge needles, and yet there seems to be a lot of equipoise as to whether bigger is better or whether we should go for the bigger tools. And now there's a lot of interest in things like nodal cryobiopsies or other needles. I'm not saying that, I'm not trying to put paint in one direction, but I was like, where do you think that's going? Like, I don't have a good sense of all that.
Yeah, I'm going to take the first part of that, but Adam, you can take the cryo part. So I'll take the 21 to 22. First of all, there was a randomized trial which suggested they're equivalent. I will tell you, in our lab, I've always been this is personal preference. 22 gauge is better for me than 21. And remember, Jasper, we're talking about DNA. It's not that big, right? Like, getting more is not that big. Now, what we don't know is getting a lot more, which would be the cryobiopsy, lymph node cryobiopsy, whether A, that gets you a lot more and undamaged DNA that you can test, and B, whether it would cause significantly higher side effect profile. And I just don't think we have the answer. There's been a few small studies, but I don't think we have the answer to that yet. Adam, would you agree with that?
Yeah, I think that's I think that's absolutely right. We have good evidence in bigger populations, in big populations, that FNA is perfectly fine for most nodes. I do wonder about the local setting. If your local biomarker testing situation is that you need a lot more tissue, well, then maybe you do need bigger tools to try to get more and more. But place to place and lab to lab, some are able to do more testing or good testing with pretty small cytology samples. And so I think that might sort of come down to what technology is being used to extract DNA and to run next generation sequencing. And then I totally agree. I think we've got small series showing it's safe, but we don't really have, I think, the data to show that it produces that much more and it's just as safe. That's one of the great things about EBUS and TBNA is how good it typically has been shown, especially for diagnosis and I think for molecular markers, and how safe it is. Some of the data for molecular markers is a little outdated. Some of these trials from 5 years ago even are looking at, well, can you do PCR for 2 genes? So as testing changes, we need more and more evidence to prove that it still holds up.
Yeah, I just want to add one other thing too, which is our cytologist is incredible, and he sometimes says, "Look, you put it on a slide, and I'll look at your slide. We will scrape the DNA off of a single slide and get you enough DNA to be tested." So this idea that bigger and more is better, we're looking for DNA. It's a very small little thing, and so we just need enough DNA. And by the way, I want to add, this is a practical matter. We do in-house at next-gen sequencing, but a lot of community places and even some universities do not. And if you are sending out your samples, you should know what there's a couple of terms you should be aware of. One's called quantity not sufficient, and we should know what the rate of quantity not sufficient in our own labs and what the company tells you their rate of having quantity not sufficient, and then also what their DNA requirements are. And honestly, and I'm not going to name any companies, but we researched this, there's different requirements for different companies, and some companies, to get down to a quantity not sufficient of less than 10%, for example, they're asking for a bunch more DNA. So I'd be careful when you're sending it out, which company you choose, and learn a little bit about that process and work with your pathologist on that.
That's good advice. I'm going to come back to something that I think you were hinting, or maybe more explicit than I thought it was, Gerard, is the idea of the pulmonary community, or in thoracic surgery. Many people in membership actually are thoracic surgeons that are trying to own the space as well, which is important. And in that space, I think the idea of shepherding a patient through the process of diagnosis, through staging, to land in an oncologist, in a treating oncology community that's going to think about them holistically is actually hard. You know, I'm finding a lot of my colleagues, myself, even at times, like I think I'm pretty plugged in, but I think a lot of people would say that, you know what, going to tumor board is a pain. It's not reimbursed. It's not something that, you know, you get time for or allotment for or support to go to. Then to sort of add the additional effort of not just ordering the staging studies, but also following up on the results and communicating them is, again, time potentially lost. And then the third part is sort of you're at the whim of your oncology community, which could be, if it's depending on who's kind of who that patient lands in first. You can imagine radiation empiric radiation. You can go to systemic therapy. Like, it's not a clear pathway in a lot of our communities. I just don't know, like, from your perspective, like, what pieces of advice would you give for our docs who are maybe struggling with this aspect?
Yeah, first of all, I sympathize with that struggle, right? Like, all I do, and to a large extent, all Adam does is cancer, right? Like, that's my job, right? And I have, we have on Tuesday, Adam and I were in clinic today. We have, 20 rooms. We have 3 medical oncologists on one corridor, 2 pulmonologists, and 3 thoracic surgeons and a radiation oncologist, so downstairs. And so, we can pull one of them right in the room with us, right? And so for us, it's a true multidisciplinary clinic. That is so hard to establish, and then there's sort of competition in the community and things like that. I think I think 2 things. One is, I know it's hard. I get it. I think the way to get, or at least to address it somewhat, is to agree on care paths, right? And also to be pretty efficient about how you use your skill set, which is highly skilled and meant to be doing one thing at a high skill set, and the skill sets of others. And so, for example, we cannot live without our nurse navigator. So when it comes to staging tests, we have either nurse practitioner or our nurse navigator arranging those staging tests. I walk out of the room, I say PET scan, needle biopsy, bronch, and those things just start automatically happening. And then I think, Jospel, the community has to get together at some point. And even if it's a smaller part of the community, let's say it's you, 1 or 2 medical oncologists, and a radiotherapist and a surgeon, I think at some point you have to get together and review the care paths, agree upon some care paths, right? This is what we're doing for stage 1. This is who do you want tested? When should we test them? Do we have reflex testing? And once those care paths are established, other than the really complicated tumor board patients, they're pretty straightforward. I do think tumor board's invaluable, and I think it's hard because it does not get reimbursed. I totally agree with you, and some people have worked around that with sort of a virtual tumor board, and worked around it with. I've had one surgeon recently tell me, my tumor board's my text pages. We text each other. Hey, I got this guy. He's coming in. Oh yeah, I'll see him next week. So like there are some other ways of communicating, and I don't say spoiled. We're spoiled in that A, this is all we do, and B, we have an infrastructure to do it pretty well, I think. But that infrastructure is not everywhere, and it's my hope though that people will try to create simple care paths to make it happen.
I agree with you. I think it's interesting though that sort of in my sort of space, it tends to see a lot of people struggle with that aspect. And I see some of the pulmonary community actually purposely not want to engage in the shepherding. They want the procedure, they want that sort of, and they do a great job with the procedure. They may do a phenomenal job with the procedure, but then the shepherding and sort of like that moving that patient through is not so smooth. And so this means my next question is, in the cancer centers, they oftentimes have survivorship programs, right? They're measured on the survivorship programs. The idea of surgeons monitor their own surgical outcomes. I haven't seen a robust survivorship program, especially in precision medicine. Do you see that landscape changing, where the pulmonary community is kind of more involved in the survivorship aspects?
Adam, why don't you take that one?
Yeah, I think that might be the case. We're definitely being asked more and more by our colleagues surgeons and especially medical oncologists, they'll see a new nodule and just oh, tumor board, put them on the list. We'll have these long lists where it's like, I just really want to look at this nodule, because looking at nodules isn't what oncologists are supposed to be doing. And so I've got multiple patients who have survived advanced lung cancer treatments, and our colleagues next door saying, hey, maybe you should start following this patient again, because they've got a couple of nodules, they're pretty small, I don't know what to make of them or when to look at them again. And so I do think that as outcomes continue to improve, that we're going to be seeing a lot of these patients more longitudinally. And to be honest, it's because a lot of them are going to be at least surviving years, whereas especially stage 3 and stage 4, most patients didn't need a pulmonologist because they weren't going to be around long enough to have another lung problem.
Yeah, and I think that to add to that, I think these people also have coexistent COPD and are deconditioned and could use pulmonary rehab. And Joshua, I get a little depressed when you tell me that pulmonologists don't want to do this. They want to make the diagnosis. And one of the things that concerns me about the interventional community, pulmonary community writ large, is I don't want to see them become the orthopedic surgeons of pulmonary, right? Like I don't want them to just walk in the morning, have a schedule of 7 bronchoscopies, run the patient through 4 robots and 3 EVISs, and then send the diagnostic yield over to someone else, because those patients need us so badly. I really do think that. And so to me, having and by the way, this is happening all throughout medicine, where RVU driven and the E&M codes for management codes are never never the same as they would be for procedural codes. And so for me, like I would love to see our interventional community, who are so skilled at procedures, also have a day of clinic to see their patients beforehand and talk about the procedure, talk about the staging, and see them afterwards, to make sure that the diagnosis is wrapped up and that they're sort of packaged right with PFTs if they're going to go to a surgeon, with looking at their other comorbidities for surgery, and also in preparation to see in a medical oncologist. I really would love our community to take that responsibility on of diagnosis and staging. I often say we're like the point guard on a basketball team. We bring the ball up and then distribute the ball to other people. So we bring the ball up, we make a diagnosis, we stage, and then we distribute to medical oncology. If we're not doing the staging, man, they can go to a surgeon and find out a month later they had a brain metastasis, right? So I do think, and it even gets to what we should be biopsying, right? So if we have a pre-treatment PET scan in somebody that looks like they have advanced lung cancer, we might find a liver lesion that could be biopsied, or an adrenal lesion. So it's really my hope for anyone listening on the call to have us involved in all aspects of lung cancer care.
No, that's fantastic. I think we share that philosophy. I just think that it's a good call out for us to kind of think through how to get ahead of this, especially when it comes to precision medicine, right? Patients are looking for what is ideally best for them at that moment with the current science that we have available, right? And so you give us a lot to think about. Sort of a couple of things, we got to think about is, from what I took some notes though, the idea of, from anywhere from PD-L1 testing to more advanced molecular testing, we need to be much more proactive. There's obviously a call, which you both gathered, is a call for us to, as Bronchoscopy Society, to really spread the word of, making sure we get enough tissue, being on top of this testing science, and working with our teammates in pathology, working with our teammates in medical oncology, radiation oncology, and others, and surgery, to really optimize that patient's pathway. To kind of get involved in various aspects of pathway development, team-based care, all that's part of it, and that to understand how to work in this ecosystem as advocates for our patients. And I can't thank you both enough for going over all that you've done and giving us all your generous time and expertise tonight. So on behalf of the Society for Advanced Bronchoscopy and our listeners, thank you so much, and we hope to have you again in the future.
Thank you, man. Appreciate it. Thank you, Adam.
Yeah, thank you, guys.
Take care.
Thanks everyone for joining and have a wonderful evening.
Cool, that was awesome.